Okay, so today I'm going to demonstrate the examination of the foot and ankle. So if I get my volunteer. So before starting the examination, it's important to assess the patient's gait, and this should be done by looking at the patient's gait from the front, the back and from the side, just so that you get a global view of how their gait is. So if we ask the patient to walk back and forth, so during the gait assessment, you should be looking for the any loading on one leg more than the other, so where they have a reduced stance and therefore they'll have an antalgic gait. You should also look for the when they're walking, for the internal and external rotation of their lower limbs and the position of their knees. So it's also important as well to assess when standing up. So in a stood position, you want to assess from the front, so looking at the medial longitudinal arches, seeing do they have pes plana, so flat footing, or do they have pes cavus, so high arch foot. And then you want to also assess the foot symmetry. Does it look symmetrical when they are weight bearing? And then you want to assess the toes, so looking for any mallet toes or hammer toes, looking for any hallux valgus, so subluxation of the first MTP joint, also looking for Morton's toes, as in this case where the first toe is shorter than the other toes, and then looking for any nail changes as well, such as psoriatic or fungal nail changes. Okay, and then if you turn to the side for me so I can see this side of your foot. So on the side you want to look then for the lateral longitudinal arches, and then looking from the back, you want to first assess the symmetry of the calf muscles, so any muscle atrophy. Then you want to assess the Achilles tendons. Is there any evidence of any inflammation and thickening at this point? And also the angulation of the calcaneum. So normally there's an angulation of 5 degrees in valgus deformity, and if you ask the patient to heel raise, this brings the calcaneum into a varus deformity as is pulled up by the Achilles tendon. Also, heel raise is a good assessment of Achilles tendon integrity. Okay. If we get you to lie down on the bed then, so I can see the underside of your feet. So looking at the underside of the feet, it's important to look again at the calcaneum, looking for any inflammation and thickening where the plantar fascia inserts, and also looking for any obvious deformities underneath, so any erosions or any bunions. Okay. It's also important to have a look at the patient's footwear to see if there's any wearing unevenly on each foot. Okay, so when you've looked at the feet from all angles, it's then important to palpate the foot. So if you just bring your leg slightly flex, there's no right and wrong way of doing this. There's lots of ways to go about this. Okay, so basically you want to feel for any point tenderness or any crepitus when you're feeling. I look down the anterior tibialis anterior ligament, palpating down for any tenderness. And then I want to look over the bony prominences, so the medial malleolus first, moving over to the lateral malleolus, and then I want to feel the tibia, the talar head, so you can squeeze, and then you can also palpate down to the calcaneum, either side towards the back, and then you can also palpate the deltoid ligaments medially, okay, feeling for any swellings or any pain, and then the lateral ligaments, so the anterior talofibular ligament, anteriorly obviously, then the calcaneofibular ligament just behind, and then the posterior talofibular ligament, which you can't see me doing, but just at the back, seeing again if there's any swelling or pain at that point. So then moving on to the midfoot, you want to palpate over the navicular bone, and then moving over to laterally over to the cuneiform, and then you want to palpate over the forefoot, so feeling down the metatarsals individually, again feeling for any pain and tenderness or crepitation. Okay. Then you want to palpate over the MTP joints, so you can squeeze them together to see if this elicits pain, And then particularly over the first MTP joint, feeling for any tenderness or pain, and this can indicate turf toe, particularly in rugby players, for example. And then also moving down to the phalanges, so distally as well, palpating those. And then you want to palpate also in between the third and the fourth toe, as this can be quite tender if you have a Morton's neuroma. And then if you just relax your leg down, so looking at the underneath of the foot, you can palpate for the sesamoid bone, which is just underneath the big toe, and this can be quite painful if you've got bursitis or a fracture in this area. Also underneath, you want to palpate for the insertion of the plantar fascia tendon, and that can be tender if you've got plantar fasciitis. Also, you can palpate the flexor tendons in that region as well. Okay. So when you're happy that you've palpated all around the foot and the ankle joint, you can then move on to movement. So you should assess these actively, passively, and assessing the functional range of motion. So at the ankle, we have dorsiflexion and plantarflexion at the talocrural joint, and then you have inversion and eversion at the subtalar joint, and then toe flexion and extension, and abduction and adduction sometimes too. So first of all, assessing active range of motion. So you want to assess dorsiflexion, so asking the patient to bring the feet up to the ceiling as far as they can. Good. And then plantarflexion down to the floor. Inversion, bringing the soles of their feet in towards them. And then eversion, bringing their feet away. Good. And then to assess toe flexion and extension, so asking the patient to bring their toes up to the ceiling. Good. Down to the floor as if curling their toes. And then you can ask them to try and abduct, so splaying their toes, and then try to adduct, bring them together, which can be quite difficult. And then you want to assess passive range of motion in the same range of motion again. So this is done by, first of all, dorsiflexion. You want to fix at the malleolus, and then asking so what I tend to do is just resting the foot on my forearm, holding the calcaneum, and then pushing the foot into dorsiflexion as much as I can. Okay, and then keeping my hand fixed at the malleolus, I want to assess plantarflexion, so pushing the foot down as far as I can. And then to assess inversion, so fixing at the tibia, so bringing the foot into inversion, and then again fixing at the tibia, assessing eversion. Okay, and then if I want to assess flexion and extension of the toes, I'll just assess on the big toe, so you want to fixate at the first metatarsal, and then bring the toe up into flexion and down into extension. Okay. Then you want to assess the functional range of motion. So first you want to assess knee flexion, so asking the patient to bring their heel into the bum against resistance. Good. And then just resting their foot on the bed. Fixing at the malleolus again, assessing dorsiflexion, so asking the patient to push up. Good. And plantarflexion, pushing down. Good. And then assessing inversion and eversion, so fixing at the tibia, assessing inversion, so asking the patient to push in. Good. And then to assess eversion, so you want to, I'll try and do this where you can see me, so fixing underneath the tibia, and then essentially asking the patient to push out against your forearm. Good. And then to assess the flexion and extension of the toes again. So to assess flexion, you want to fixate the forefoot and asking the patient to push up against you. Good. And then to assess extension, again fixating at the forefoot and asking the patient to push up. Good. So then to assess different types of injuries using special tests, the first one you can do is Tinel's test, so assessing for tarsal tunnel syndrome. So here you palpate the posterior tibial nerve, and if this causes pain and symptoms in the dorsal of the foot distally, then this can represent the patient has nerve entrapment in that area. Then moving on to ligament laxities, so you can assess the anterior talofibular ligament laxity, so getting the patient to bend the knee slightly, okay, relaxing it over, and then bringing the foot slightly into plantar flexion, so slightly into plantar flexion, fixing at the joint line, and essentially grabbing hold of the calcaneum. You want to anteriorly translate the calcaneum and talar over the tibia. Okay, and a positive test will show increased anterior translation in that region. Okay. You can also assess for the other ligament laxities by getting the patient to sit on the end of the bed. Okay, and then assessing first, again, ATFL by getting the patient to go into plantar flexion, and then stressing inversion. Okay, to assess the CFL, you get the patient to put the foot into with the foot into neutral, and then passively invert. Again, to assess the deltoid ligament, again you can put it into neutral and evert. And to assess the posterior ligament, posterior talofibular ligament, get the patient to put the foot into dorsiflexion and invert again. And this is obviously tested between the two legs, the two joints, to see whether or not there's laxity on both sides. So the next tests that you should be looking to do for syndesmosis injuries, and the one test in this position you can do is to do the dorsiflexion external rotation. So in this patient again, you want to get the foot into maximal dorsiflexion and externally rotate the foot. If you get pain anterolaterally on that side, then it suggests that there's a syndesmosis injury. If we get you to lie back down, with the foot slightly flat, knee slightly flexed, we want to then do a squeeze test where you squeeze in the tibia and fibula against each other, starting proximally and working down. If there's any pain during this test, there's just again syndesmosis injury, with the theory being the more proximal the pain, the worse the prognosis and more severe the injury. The next test that you can do is for an Achilles tendon, so if you roll over, it's called Thompson's test. And essentially, if, bring your feet over, so if the Achilles tendon is intact and you squeeze the calf, there's a degree of plantar flexion, as you can see here. If it's ruptured, then there'll be no plantar flexion and it won't move. Okay, you can roll over. So to finish the examinations, you should also examine the lumbar spine, looking for any radiculopathy pain, such as sciatica, by doing a straight leg raise. It's also important to undertake biomechanical testing, so such as squat testing or standing up from a sitting position to see what the hip flexion and ankle flexion is like. And there's also, you can test by doing a straight leg raise. And that's the end of my examination.